Welcome back to the deep dive. We have some incredible material you sent in, and today we're looking at a procedure that sounds almost simple,
Right.
marking a spot inside the body, but it's actually this high wire act of precision. We're talking about endoscopic tattooing.
We are, and we're getting a real masterclass on this. The source you sent is a video called HCC 1472-15B3 Injection Tattoo, and it's from Dr. Gadamukala S. Raju's YouTube channel.
Dr. Raju, okay.
And he walks through every single technical detail, how to mark these lesions safely, effectively, for whatever comes next.
So that's our mission for this deep dive. We really want to get into the why, not just the steps, but the intense safety thinking behind it. Why do you need to find a spot again? What's in the toolkit?
And crucially, how do you avoid a catastrophic mistake?
Exactly.
Well, the fundamental goal here is all about localization. I mean, think about it. If you have a small, suspicious polyp, maybe an early cancer,
Right.
and a surgeon needs to remove it later, they need a beacon, the bowel is, it's mobile, it moves around, and finding a tiny lesion weeks later,
Almost impossible, I'd imagine.
it can be. So that tattoo, that's the breadcrumb. It's the permanent, visible marker that says, operate here.
Okay, so if it's permanent, you can't just use any ink. This has to be a very specific, sterile toolkit. What does an endoscopist actually need on the table?
It's actually pretty simple, just three main items. First, you've got a basic 10 cc syringe. It's just filled with saline.
Okay, salt water.
Exactly. Second, you have the tattoo itself. It comes in a pre-filled syringe from a commercial vendor, so it's all standardized.
And the third piece.
That's the injection catheter, the special needle that goes through the scope.
Now, this is where, from the source, it seems like the prep work is already a safety barrier. It starts with this whole flush routine, with the saline first. Why is that?
That saline flush is absolutely critical. Use that first syringe, the saline one, to push fluid through the catheter.
Just to make sure it's clear?
To make sure it's clear and working, then you detach that syringe.
But then the prep for the tattoo itself is a bit weird. The video says you have to shake it.
Oh, that's vital. You have to shake that tattoo syringe really well
Why?
because the solution is a suspension. The dark carbon particles, they'll settle to the bottom if it just sits there.
Ah, so you just inject clear fluid and leave a weak mark.
You'd leave a terrible mark, yeah. So you shake it until it's a uniform dark liquid.
Okay, so it's shaken, you attach it to the catheter, but you don't fill the whole thing with ink. You leave this, cushion of saline at the tip. How does that work?
You inject the dark tattoo solution, but only until you see it reach the biopsy port of the endoscope.
And then you stop.
You stop right there.
Yeah.
What that does is it leaves the last part of the catheter, the part that's actually going to puncture the tissue, filled with that clear saline.
And that saline cushion is the key to everything that comes next.
It's the key to the entire safety check.
Okay, this is the part that really blew my mind. The success of this whole thing depends on placing the mark inside the colon wall in a layer called the submucosa.
Right.
If you go too far, you punch right through the colon and into the main body cavity.
To a peritoneal cavity, yeah.
Mhm.
If you think of the colon wall like a thick tire, the submucosa is that safe, padded layer on the inside. The peritoneal cavity is the sterile space on the outside.
And injecting ink there is the catastrophe we're trying to avoid.
It causes massive inflammation, infection, peritonitis. It's a surgical emergency.
So the endoscopist pokes the needle in, thinks they're in that safe submucosa layer, and then they use that saline tip for a safety check. The video calls it the tap-tap technique.
Exactly. Instead of just pushing in the permanent black ink, they just tap, tap, tap on the plunger.
And that squirts out just a tiny bit of the clear saline.
Just a little bit. And what you're looking for, the visual confirmation, is something called a bleeb.
A bleep.
Yes. If you're in the right spot, in the submucosa, that saline will create a nice bleeb. It's a small, immediate white mound, a little bubble under the surface.
So that bubble is proof. It proves the liquid is contained inside the wall.
It is the only proof. If you tap and you see nothing, you are outside the colon. You're in open space.
And you pull back immediately.
Immediately. You withdraw and you reposition. No questions asked.
It's amazing that with all the tech we have, the whole safety system boils down to seeing a tiny bubble.
Yeah.
It's all based on the endoscopist's trained eye.
It really speaks to the manual skill of the procedure. I mean, that immediate visual feedback of the bleb forming, it's still the gold standard. It's instant proof.
So once they see that bleb, then they push the rest of the solution.
Then they can inject more, filling that saline bubble with the actual dark tattoo material.
And the final move is just as critical. You have to start cleanly to avoid, as the source says, making the whole area dirty.
That's right. You have to stop injecting before you pull the needle out, if you're still pushing as you withdraw.
It spills everywhere.
It spills into the colon, makes a mess, and can obscure the very lesion you're trying to mark for the next person. Every single step requires precision.
So once you've mastered the how, we get to the strategy, the when and where, and it seems like this changes completely depending on what you're marking.
Entirely. Let's start with the highest stakes situation.
Hmm.
You found a cancer, and the patient's going to surgery.
Okay, how does the marking strategy change for that?
For surgery, you need to provide navigation points for the surgeon. So the rule is you place at least 3 or 4 tattoos.
Not just one.
3 or 4, and where do they go?
Always distal to the lesion.
Meaning towards the anal side. Why always distal?
It's about how the bowel moves and folds.
If you put it proximal or right next to it, it can sometimes get hidden from the surgeon's view. Distal gives them a clear, unambiguous landmark. It tells them exactly which piece of the bowel to take.
And even with those 3 or 4 spots, there's an order to it. You start in what's called the dependent portion.
Yes, that's another bit of risk management. The dependent portion is just the lowest point in that section of the colon because of gravity.
Ah, so if there's a tiny leak.
Gravity pulls it down and away from the main area. It contains the mess. You do the lowest spot first, then work your way up.
This sounds incredibly painstaking. If an endoscopist needs to put in 3 or 4 of these perfect tattoos, do they have to go through that whole prep routine? The flush, the shake, the partial fill for each and every one?
They absolutely should. The video is clear on this.
Yeah.
To get a beautiful tattoo every time, you often have to take the catheter all the way out, flush it with saline again, and repeat the entire prep.
That sounds slow.
It is slow, but rushing is how you poke through the colon wall. That risk is just, it's not acceptable. So you take the time.
Okay, let's shift gears. A less intense situation. It's a benign polyp, something that just needs to be checked on or removed later.
The strategy simplifies a lot. For a benign polyp, you only place 1 tattoo.
Just one.
Just a single coordinate is all that's needed.
But that one mark has to be placed very, very carefully.
It does. The rule is 3 centimeters distal to the lesion, again, on the anal side, and, this is key, on the same plane as the polyp.
So if the polyp is on the top wall of the colon, the tattoo goes on the top wall.
Exactly. 3 centimeters away. It makes finding it later so much easier. And this leads right to the documentation, which is non-negotiable.
The photo.
You have to take a photograph that shows the lesion and the tattoo in the same single picture. That photo becomes the map for the next doctor.
So even though we need these tattoos, there are also places where you should just not put them. Avoidance zones.
Right, there's a geography to this. There are a few places where a tattoo is generally a bad idea.
What are they?
First, you should avoid tattooing the cecum. It's a major landmark at the beginning of the colon, so it's very easy to identify on its own. A tattoo there is just redundant.
Okay, what else?
And generally, you avoid putting a tattoo for a standard polyp in the rectum.
But there's a big exception there.
A critical one. If the lesion in the rectum is a small carcinoid tumor, those can be tiny, really subtle, and they need precise removal. So for that specific case, a tattoo is actually really important.
We've talked about precision, but it turns out putting the tattoo too close to the lesion is also a problem. Why is that?
Because the tattoo ink itself causes an inflammatory reaction in the tissue. And over time, that reaction creates a lot of fibrosis.
Scar tissue.
Exactly, a lot of dense scar tissue. And that fibrosis can make the next procedure a nightmare.
How does it make it harder?
Well, when you do an endoscopic resection, you need to lift the lesion up away from the deeper muscle layer. Fibrosis basically glues everything down. It makes the tissue stiff. You can't lift it properly. And your risk of causing a perforation goes way up.
So you're not just marking the spot, you're accidentally anchoring it down.
You're making it technically much, much more difficult to remove safely.
This is obviously a team sport. The source really emphasizes that the technician or the assistant isn't just handing over tools. They're an active part of the safety system.
They are the safety monitor. Their first job is to be the second brain, to make sure the team actually does the tap-tap technique.
A reminder, basically.
A verbal reminder. In the heat of the moment, people can take shortcuts. The technician's job is to make sure the bleb is confirmed every single time.
And their second job is auditory. They're actually counting out loud.
This is just brilliant for risk assessment. The technician should count loudly as the ink goes in. 1 cc injected, 2 cc's injected.
Why does that help?
Because it gives the endoscopist real-time feedback. If the assistant shouts 3 cc's, and the endoscopist is only seeing a tiny little bleb.
It means the fluid is going somewhere else.
It's a huge red flag that the ink might be going into the peritoneal cavity. It's an immediate audible warning to stop and reassess. The vigilance of that assistant is literally helping to decide if the procedure is safe or not.
So this whole system, the tap-tap, the counting, it's all designed to prevent that one major error of injecting outside the colon. It really brings home the risk.
Absolutely. One mistake can confuse a surgeon. It can turn a simple laparoscopic surgery into a huge open operation. It just makes the patient's whole journey so much more difficult.
This deep dive has just been, it's incredible. It's shown the extraordinary precision needed for what sounds like a simple task. We've learned that a good tattoo is all about that prep.
The saline flush, the shake, the partial fill.
And that critical tap-tap technique to get the submucosal bleb.
And we saw how the whole strategy shifts based on what you find.
Yeah.
Multiple tattoos for a cancer versus that one single perfectly documented mark for a benign polyp.
It really highlights the cognitive load on the entire team. They're juggling the technical skill, the anatomy, the team communication, and the long-term surgical plan all in one moment.
It's a lot. And we learned that placing a tattoo too close creates fibrosis, which is a serious problem for the next person. And that raises a really interesting question for you to think about.
Yeah.
Given these risks, peritonitis from a bad injection on one hand, and the technical difficulty from fibrosis on the other, how do you think teams decide when the risk of losing a lesion without a mark outweighs the immediate technical risks that the mark itself creates? What stands out to you as the biggest challenge in this whole high-stakes process?